Okay, so let's differentiate between seizures and epilepsy. Seizures, even if you have multiple, everybody has an idea what a seizure is, right? Okay, so as defined, these are abnormal episodes of abnormal motor, sensory, autonomic, psychic activity. So there are different types of seizures. For purposes of our discussion today and for testing, we will only test and discuss one type of seizure, which is the generalized seizures, also known as tonic-clonic seizure, because this is the most common type. There are many other types. There's silent seizures, there's absent seizures, etc. But we're only testing the most common type, okay, which is the generalized or tonic-clonic seizures. Okay. If you have one or more seizures, but every time you have a seizure, there is an identifiable cause, meaning we can pinpoint the neurologist can comes into consult, checks you out, and then the neurologist runs some tests, labs, for instance, CAT scans. If there's an identifiable cause that led to the seizure, we look at the causes shortly, then it's simply called a seizure disorder. However, if you have one or more, if you have two or more seizures with no identifiable cause, we call that epilepsy. Any question on the difference? Okay. Let's go now to the causes. What causes a seizure? Here are the, no, sorry, these are the classification. Again, we're going only to test which one? The generalized one, okay? The generalized, which is also called tonic-clonic type. These are the causes. So again, if there are causes identified, what do we call your seizure? Is it seizure disorder or is it epilepsy? If your seizure is caused by any one or more of these, is it seizures or is it epilepsy? It's seizures. Okay, what's the main difference again? When do we call you as having a epileptic disorder? Okay, if you have two or more seizures with no identifiable cause. Are we clear? Okay, so these are the possible causes of seizures. So yeah, allergies, a brain tumor, fever, for instance. For instance, for me, I've had multiple seizures in my first year of life. I've had at least 4 or more. Each time was preceded by a fever. So my mom said, "You were a sickly kid." So every time you have a high fever, you have a seizure. Okay, so on my way to the doctor, I have a seizure already. So I didn't tolerate high fevers very well, but none since then. So after that, I was able to tolerate fevers now, and then I stopped having the seizures. Okay, so I didn't have epilepsy. Okay, manifestations, again, we will only look at the tonic-clonic seizure. So the patients will have unique ways to have a seizure. Some will have aura. Aura is like a pre-ictal phase. There are 3 phases of a seizure. We'll look at that shortly. So there are many examples here, different patterns that the patient will manifest the seizure. I won't read everything for you. Now, the patient will have an aura. These are the most common auras, but the patient may have a totally different aura, right? Aura, again, is a pre-ictal sensory motor manifestations. Okay, so some people will report, "Oh, I smell this odor," and then they can tell, "Oh, I'm about to have a seizure because I'm smelling this odor." Okay, but nobody else can smell it. Right? Do you understand? So it's unique to the individual. So some people will have, let's say, I went to school with Stella. Stella, I remember from 1st to 3rd grade, was in my class, and she would make these sounds. She would go, she'd do that for probably 2 minutes, and then we know after 2 minutes she's going to cease. All right. Yeah, and exactly like clockwork. Okay, she makes those sound. 2 minutes later, she's on the floor. Okay, she's on the floor, jerking and having the seizure already. Right. Most seizures last about 1 to 2 minutes. However, if it lasts 5 minutes or more, then that is a medical emergency, because during a seizure, there is less oxygen flow to the brain caused by the seizures. Plus, not to mention the patient's how much oxygen is the body consuming if their whole body is contracted like this in a clonic state. So the no, sorry, tonic state. You know, the muscle contracts, every single muscle in the body contracts, and then followed by a jerking motion. So how much oxygen is being used by these muscles? A lot. But the patient's breathing, is it supplying the increased oxygen consumption? No. So therefore, is there adequate tissue perfusion? Is there adequate oxygen to all the tissues, especially the brain? No. Okay. So again, the emergency is if the patient's seizure lasts 5 minutes or more. Right? I think the actual definition is more than 5 minutes. We'll get to that later. And then let's clarify that. So the pre-ictal again. So this is the pre-seizure episode. This is not all people will have an aura or a pre-ictal. Some people will just have nothing. You know, they'll just stare blankly. Okay, no manifestations. But some people will have these. I gave you the example of Stella. So Stella was making those funny sounds, right? Unintelligible sounds. She was making. Okay, she was. That's the best I could recall. Okay, I don't exactly know what that exact sound she was making. And then she's followed by the tonic. Okay, so that would be the muscles go into a contraction, and then followed by clonic or the jerking movements. So that would be the seizure episode itself, and then the post-ictal would be after the seizure. Post-ictal period usually sends the patient to an unconscious state, meaning the patient goes to sleep. Okay, so she's tired because it's a very tiring episode. Okay, so the seizure is very tasking mentally and physically. So the patient usually goes to sleep. And these are the other things that could happen. So patient may injure their tongue or become incontinent. One thing is for sure, though, they will have no recollection of the event. They will not be aware of what happened. Okay? So they have no idea what happens during the episode, and of course after the seizure. Okay? They'll just, for people with epilepsy, they'll just know that they had a seizure because let's say they live alone, and then they find themselves either on the floor, and then they see these injuries, these bruises, these cuts that they sustain. Oh, where did I get? Oh, I must have had another seizure. Okay, so that's when they find out. To diagnose a seizure, of course, when we see it, then we observe that it's a seizure. However, the doctor will confirm, the neurologist can confirm by ordering an EEG. EEG is like ECG, but the electrodes are multiple. There are many more electrodes, and they're, instead of being placed on the chest, this will be placed on the head. Okay, so this will measure electrical activity of the brain. So if there's increased electrical activity, then that will confirm that the patient had a seizure. Okay, so the neurologist will read the test. So this is what happens again during a seizure. So the patient may have an aura. Okay, some patients may have a trigger. So let's say you've heard of people getting a seizure from lights, like strobel lights, for instance, or different sounds, maybe, or temperature. So some people may have a trigger. And then the aura, again, is like a premonition or, again, a warning, okay, that the seizure is about to happen. And then again, once it starts, the body goes into a stiff state. Okay, all the muscles contract, resulting in low oxygen in the body because all the oxygen is consumed by the muscle contraction, then followed by the clonic phase, okay, the jerking motion, and then of course the post-ictal phase can last between 30 minutes to several hours depending on the patient. And here it is after the seizure. So our role here in the nursing care part is, of course, what's your number one concern here? Patient has no control over these movements. So what's your injury? So safety is our number one concern. Okay, so we protect the airway and then protect the patient from any injuries. Okay. We'll get to that next. Very important is if the seizure is witnessed, meaning you saw it from start to finish, and we know that the emergency is if it's lasting more than 5 minutes. So what's the most important role of anyone who witnesses a seizure? Okay, so once it starts, look at the time. What time did it start? And yeah, so it's nearing 5 minutes already. What do? Call somebody, okay? Because that's already an emergency. That's a medical emergency. This patient may die, or if they survive, they may suffer permanent brain injury. So we saw the causes of a seizure. Will we see causes here in epilepsy? No. Again, if the patient has 2 or more seizures, more than one seizure, but there is no identifiable cause, meaning unlike here wherein we saw a metabolic disorder, for instance. Let's go back to the list. Here, the patient has no brain infection, no meningitis, no encephalopathy, no encephalitis, no drug or alcohol withdrawal, no fever, no head injury, etc. So therefore, does the patient have a seizure disorder or epilepsy? Epilepsy already. Okay, again, if there's no identifiable cause, we ran tests, we took blood, we ran CAT scans, MRI, patient confirmed, the EEG shows they had a seizure, but then there's no attributable cause, then the patient is diagnosed with epilepsy. Because why do we need to distinguish? What will we do if the patient has a seizure disorder? What do we do? Treat the underlying cause, right? So the cause is drug and alcohol withdrawal, for instance. So that's what you treat. Okay, then meaning if you eliminate the cause, you eliminate the acidosis, for instance. If it's a cause by, let's say, the patient is in dialysis and they missed a whole week of dialysis, you can just imagine the level of acidosis they have because of all the uremia, right? So all the waste products are not being removed. So of course that will go to severe acidosis and cause a seizure. Okay. So of course you treat the underlying cause, then there will be no more seizure. Here, how do we treat epilepsy then? If there's no identifiable cause, what will we do? What's the only way to manage this? What type of medication? Anticonvulsants, anti-seizure medications. Okay, so that's the mainstay of therapy. You understand? Yes. Seizures or epilepsy? Okay. Some state, again, seizures or epilepsy? Okay, seizures, no restriction because it's seizures. Because why again? Because there's an identifiable cause. We know exactly what caused the seizure. So the treatment would be, of course, to treat the underlying disorder. So let's say it was fever. Are you going to have a fever forever? No, we treat the fever and then it's gone. You have no seizures. You follow?
Yes.
Again, if it's epilepsy, however, that's a different story. Now, as far as which state restricts your driver's licenses, I don't have that data. You can easily look that up on the federal website, but yeah, some states can restrict mhm. Again, I don't know each state's law. Okay, so each state has specific restrictions. Okay, so I can't. It's not discussed here. Okay, and it's not going to be tested on the NCLEX either. All right. So here is your nursing responsibility with people who's having a seizure. I mean, I have to read the whole thing, but the point here is you place the patient in a safe situation. Okay, maintain safety. Let's say they're having the seizure right at the yellow strip on the subway platform. What are you gonna do? Because it says here, do not restrain the patient's movements. It says do not restrain the patient, do not hold them. Okay, just let them go. But so you just let them go. They're rolling over to the train tracks. Okay, so that's the that's what they're saying here. So no, here, do not attempt to restrain, but you're not restraining, but you are protecting them from injury. Okay, so they don't roll over onto the train tracks. Okay. Here, used to be during my time, we were putting padded tongue blades into their mouth to prevent them from biting their tongue. Then that led to several injuries, lawsuits. So now we stop that practice. Okay, do not put anything into their mouth. It's dangerous. They can actually aspirate, or they can break their teeth in the process. So no more. Just if they bite the tongue, then so be it. Okay. Then after the seizure, put them in a recovery position, which is usually side lying. Okay. If there's any reason you can't put them side lying, at least elevate the head of the bed. Again, we don't want them aspirating because they're unconscious. We don't know for how long. So unconscious people cannot protect their airway. So maintain safety. Okay. So I institute aspiration precautions. Okay. So now, taking these into consideration, when you have a patient who is known to have epilepsy or seizure disorder, and the doctor writes seizure precautions, give me 5 things you're going to prepare. Suction, oxygen, lower the bed, hide the railings, and what's the 5th?
Non-restricted clothing and using
Give me 4. IV access. Okay. What is the IV access for?
It's for medication.
Because remember the status epilepticus, which is the medical emergency. Can we start an IV during a seizure?
No.
Good luck putting in an IV. Okay. Because the patient is very tense, all the muscles are contracted. It's impossible. Or if you attempt, you may either injure the patient or injure yourself. Okay. That happened to me one time. Well, I didn't stick myself, but of course, we just got lucky. I got the IV in, but things could have been worse. Okay, so we should have had that IV access before the patient went into a seizure because we knew he had a seizure disorder. Okay, so it's just poor timing that the patient lost the IV access and we needed it. There are ways to prevent, but there's really, if it's epilepsy, I mean, we can't. Okay, there's it's almost impossible to prevent epilepsy, but you can decrease the incidence. The number one known cause that can lead to epilepsy is head injury, although there's really no definite proof of that, because not all patients with head injury goes on to develop epilepsy. Okay, but that's one thing we can control. So the most successful way, I should say, not the only way, there are surgical options, but majority of people with epilepsy are treated with medications. Some undergo surgery, but they're not really successful and popular. That's why most people are on the medications. Okay, so doctors will give them the data on all the options, and then based on the statistics that the most successful treatment is the drug therapy. So that's why people would just stay with the pharmacologic treatment. Now, there are a few things you need to understand about the pharmacologic therapy. These drugs must be taken regardless of the patient's condition. However, will our lives, the epilepsy patients' lives, always be perfect that they can take the oral capsules or pills religiously? No, there will be times when they get sick, for instance, or they get hospitalized, or they undergo surgery wherein they will be placed NPO, or they have some GI issues wherein they can't take the medications, right? So what should be done during those conditions, those instances wherein they can't take the pills? What do we do now? Just pray that they won't have a seizure? Okay, so that means they have to go to the hospital. So let's say there's a condition wherein they absolutely can't take anything by mouth. Let's say they're undergoing a major surgery. So what should be done? They'll be given the IV form of the drug. What if they're not having surgery, but they're just sick? Okay, they have the stomach flu, really serious case. Okay, they're vomiting all the time, can't keep anything down. So what should we do? Same thing. They have to go to the ER and get it IV. What if the patient is NPO for some reason, and then no, they're not really having major surgery, but the order is NPO. So what's your nursing responsibility? The patient's on anti-seizure medications.
Another NPO.
Okay, you notify the physician and tell them, doctor, my patient's on Dilantin, okay, or phenytoin, for instance, or levetiracetam, whatever anti-seizure medication they're on. Doctor understands automatically, oh, they need that. So they may say, okay, I'll write an order, give this specific drug with sips of water. All right. So, but your responsibility is to make sure they get the medication. Okay. It's very important, because what will happen if they stop the medication? And the most common cause of status epilepticus, which is the emergency, is sudden abrupt withdrawal of anti-seizure medications. Okay, so very important that they continue. So it's not limited to just this drug. What so far you're in your 4th semester now. What other drugs must be continued regardless? Yeah, something like this. So what other medications must always be continued, meaning you cannot stop them abruptly?
Like in general, or just?
This is your 5th semester. Come on, you should already know what these drugs are. That you absolutely, because otherwise, this comes up on the NCLEX, and then these drugs are listed. What are you gonna choose? Just the anti-epileptic medications?
No.
What other medications? Be specific, because it's not all. What specifically? We talked about these already. So what so far in this semester? Not really. We can stop the Jackson.
What you talking about? TV? No, medication that you can't stop abruptly. Oh.
Remember beta blockers?
Yeah, I was knowing.
Beta blockers cannot be stopped suddenly. Okay? Because why were patients placed on beta blockers? Here we go again with the hypertension. Beta blockers are not blood pressure medications. They're for heart failure. Okay, they're given to keep the workload down. Remember, heart failure patients depend on beta blockers. Are we clear? Not really. We can stop anticoagulants abruptly, okay? Steroids is another thing. One more, which we talked about this semester under endocrine. Remember levothyroxine? Levothyroxine, can you stop that suddenly? No, their body depends on that, right? No thyroid hormone, what will happen to all metabolic activity? What could happen? They could develop. What's the complication again? It's hypo. The I think is thyroid, hyperthyroidism. What's the complication? Myxedema. Very good. Okay. So for the drug specific responsibilities, they took it out from this edition of the textbook. So that would be one less thing for you to memorize. However, they did put this paragraph right here as generally applicable to anti-seizure medication, especially phenytoin. Phenytoin is known to cause gingival hyperplasia, swollen and tender gums. So therefore, what's your responsibility when a patient is on phenytoin? Religious or what's the adjective? Diligent oral care. Okay. Yeah, consistent oral care. There are others here. Please read them. Okay. So most of them will have hepatic effects, meaning they are toxic to the liver. So that's why people on these medications must be monitored regularly for their hepatic and renal function to avoid toxicity of the medications. And of course, again, the successful control of seizures in epilepsy patients depends on therapeutic drug levels of these medications. So they have to be monitored regularly. I'll skip the surgical part. Again, I seldom see people who undergo surgery for epilepsy. Okay? Most of them are on, majority are on pharmacologic treatments. Oh, I stand corrected. There is a table here. So table 61-5. They do have the medications. I forgot, it was probably the 14th edition that didn't have it. This one has it. The ones I highlighted will be on the exam. These are the most commonly used or prescribed anti-seizure medications. So you have them. Can I skim through this or you need time? Okay, these are the ones I'll test.
This record is not already put this.
Maybe.
Same day, I gotta wait like. 2 months into the same night.
Yeah. Maybe. Something you have to understand, okay? This is an in-person class. I'm not obligated to record any lectures because this is an in-person class. This is all courtesy. All right?
So thank you, we appreciate it. I watched.
All right, so this is a drug chart. So as usual, what will you be tested on? Serious side effects and nursing responsibilities. Of course, nursing responsibilities apply to the side effects. What do you teach the patient? What do you monitor? Having epilepsy, does this affect the patient psychosocially? Okay, this can create stigma, right? This can create maybe bullying in school, correct? Yeah, this affects a child, for instance, or even in adults, right? Um, does it cause embarrassment?
Yes.
Okay, because you have a seizure somewhere in and it happens in public, right? And then you don't know what happens to you. What do people do nowadays whenever something happens? Video, and then someone puts that up online, and here you are, you're having a seizure, and then you become a TikTok star, right? Okay.
Viral.
So here are the nursing care, okay, for patients on the phenytoin especially. Okay, so meticulous oral hygiene, oral care to prevent the gingival hyperplasia. And here are more teachings, chart 61-6. This will help ensure medication compliance. Okay, again, because successful management of epilepsy depends on compliance with the medications. Patients must be aware that before they start any over-the-counter or prescribed medications, the doctors must be aware of their medication list that they're taking anti-seizure medications. Because, example, if you look up phenytoin on the drug book, that drug has probably about at least 2 pages of drug interactions. Okay, phenytoin. If you look under drug interactions on the drug book, it will have the longest list of drug interactions. So for me, I just assume that it's going to interact with every possible drug that I'm giving with the patient. So I never give it right away. I look at the drug list and then I look it up. Or just not give the drug together with the rest of the medications to be safe. Okay, and there's even a warning on the same drug phenytoin when a patient is on tube feedings. You're supposed to stop the feeding 1 hour before and 1 hour after administration of phenytoin. Right? I see it a lot in the nursing home. In my experiences in the nursing home, because patients are on phenytoin, patients continue to receive the tube feedings, and then they wonder why the patient suddenly had a seizure. Because was the patient absorbing the drug? No. Tells you exactly stop the feeding 1 hour before and another hour after administration of the drug. And I won't read that for you. Let's go to status epilepticus. So here is the emergency. Oh, it is 5 minutes or longer. Okay. So status epilepticus is a seizure lasting 5 minutes or longer. Or if a patient has more than one seizure within a 30-minute span. You understand? Meaning, if the patient only had 30 minutes of rest and then they had another seizure, did they fully recover from the last seizure? No. So this is still status epilepticus. Again, either patient had a seizure lasting 5 minutes or longer, or multiple seizures within a 30-minute period. Meaning the post-ictal period was only 30 minutes. That's all the rest the patient had, and then another seizure happened. That is still status epilepticus. So how do we stop the status epilepticus? There are 2 drugs approved. Either you give IV what? Diazepam or lorazepam. So both of these benzodiazepines. There are others, let's say phosphophenytoin, but that's not really that's not a benzo, that's a anti-seizure medication. So the first drug given to stop the seizure is a benzo, IV diazepam or IV lorazepam. That's why we need what again? An IV access. So all patients on seizure precautions must have the IV access. And then the rest, of course, is the chart we saw earlier about what to do during the seizure and then after the seizure. Okay? You know, your nursing responsibilities about maintaining safety. Any question on seizures and epilepsy. Okay.